Hey guys, so I ran into a friend. Do you want to say your name? Barbie. So basically we have to sign this book when we come into placement.
That she never knew about.
Does it have any? Okay, no confidential information on that. Yeah, which I've never done, so she's doing it for me now. Yeah. What a lovely person. But yeah, she's on postnatal ward today, so she's leaving me.
Yeah, unfortunately.
But yeah, tell her to also vlog. We need more student midwives vlogging. No. Oh. Hey guys, having an amazing shift once again. Just wanted to share some of what I've been learning. I've got this head here. So I'll just explain this first because I conducted a vaginal examination on a lady. And basically, babies are actually born this way with their head coming out like this, and this is an OA position, which means occiput anterior, and the occiput is the back of the baby's head where there is a small fontanelle like this, and then you've got suture lines. So when you conduct the VE, if the baby is OA, occiput anterior, this is what you should feel. You should feel suture lines. So yeah. My lady though, her baby had caput, which means swelling on the baby's head, and with caput, basically that could be blocking you from feeling the fontanelle, so I couldn't feel it, but the midwife said she went to the side a bit and she felt a little bit of it and the suture line, so she confirmed that it was OA, occiput anterior. This is the first time I'm actually understanding it properly. So some babies could be born like this, or the head coming this way. This is OP, and this means occiput anterior, because the occiput is at the back. I mean occiput posterior, because occiput's at the back. So posterior for the occiput being at the back, anterior for the occiput being at the front. Some babies can be born like this. That's a bit scary, face presentation. But yeah, we went through that, and I wish I could keep this because it makes so much sense to me. But yeah, so today I've had a lady, a really nice lady. I've really enjoyed looking after her. So she is a Jehovah's Witness, so she doesn't want any blood. But basically, we're able to give her, I've got all my notes here, so I'm trying to remember. We're able to give her, okay, I found it. We're able to do something called cell salvaging, and that means it's like a placebo of blood in a way, and it's something, I haven't seen it before, but it's something that's used to open up, to expand the platelets. So the blood in the body is going to think that there's more when there actually isn't, but it's kind of a way to buy time, I would say, and also clotting factors, so we can give her vitamin K and stuff like that. But actually accepting blood, she's not on that. And Jehovah's Witnesses actually they normally don't accept blood, but they normally see a doctor and consultant and go through things. But she said that the smaller hospital she was at before, they didn't have that option, which is why she moved here. But yeah, it's been great looking after her. We went in to see her. She has an epidural. She wasn't mobilizing, she wasn't drinking or anything. So as soon as I met her, I was like, this is gonna be a instrumental forceps 1-2 or C-section, because she's not moving, so how's baby gonna descend down? She's got epidural, so she's not gonna be able to feel when she's pushing. But fast forward to now, I thought the room was needed. Don't worry, I'm okay, I'm allowed to be here. But yeah, fast forward to now, the epidural's not working that effectively. She's got lots of feelings. She was walking, standing up, she was mobilizing, she's drinking a lot more, and she can feel her contractions. I think we're gonna be okay, fingers crossed. Another delivery, I'll be on number 13 if that happens, but let's see. Yeah, so I haven't seen someone in labor from the morning in a long time, so basically what we did was we introduced ourselves, we made sure everything's okay, changed her bedding and the pads, any mess that was there, took observations, her blood pressure, her pulse, her temperature, her respiration rates and her oxygen saturation. I spoke to her and her partner about their wishes, birth plan, went through her notes and offered them breakfast, and we made them toast and got them tea and coffee. So that was a great start to the morning. And then throughout the day we're following the guidelines and just doing the fetal heart rate. She's actually on the C.O.G, so we're just kind of just monitoring it. She had reduced variability, which somebody had called hyperstimulation, but the doctor confirmed that it's not called hyperstimulation, it's called fetal tachysystole. And this is basically when there are more than 6 contractions in 10 minutes. And actually go back, that happened, the hyperstimulation happened when the fetal tachysystole happened when she was induced, because she was actually induced upon request. She requested induction, don't know why, and I was thinking, oh, why did you do that to yourself? But it's fine. So yeah, fetal tachysystole, something I've learned today. That's when there are more than 6 contractions in 10 minutes. So she was induced with Propez. They took the Propez out because there were more than 6 contractions in 10 minutes. Fast forward to now, there's reduced variability on the C.O.G trace, so baby's not moving as much. So there was cycling, which means baby's sleeping, but that was going on for so long, so I was kind of worried about it. But when we conduct the vaginal examinations, the baby is reacting, so we can see that baby is actually fine. We'll just keep an eye on it. Yeah, what else is important? Or something else I learned: West African women, or let me not say that, African women in general, because of the pelvis shape, their babies are usually in the OP position, so like this, and then the baby might end up, was it like this? Yeah, I think like this. Yeah, like this, in this position. So babies are often born like this, or they're like this, and then they will turn later on. I'm still trying to understand it, but yeah. So that's common in African ladies because of the shape of their pelvis, apparently. And the midwife was like, what's the evidence for this? And the doctor was like, there's no evidence, it's obstetrics, it's not evidence, it's experience based. That's what she's experienced. So real quick, something I've also wanted to speak about is the epidural. As soon as I knew she had epidural, I was like, oh, baby's gonna be born by ventouse or forceps, whatever. But at the same time, I shouldn't have that judgment, and I have to take other things into consideration. And the fact she's got fibroids, that fibroid here is at the fundus, which is the top part of your bump. Imagine how painful that fibroid is. So how would she be coping with the contractions and everything without the epidural? Sometimes it's necessary and needed. So I take back my thoughts about why did she do that. She hasn't been educated about blah 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 blah. Sometimes it's necessary. Why put yourself through all that pain when there's help there? So yeah. Anyway, so what happened after I left you guys? So yeah, I came back into the room and we started pushing. Mum's pushing was not the most amazing, and she could feel what she was doing, but she was very tired. I did say to her, remember we spoke about this, now is the time to use all of your energy. Now we got to use all of your energy and get baby out. Baby's got to go through a curve and go up, and the pelvis isn't just a straight road down, like it's complicated. So the pushes really need to be effective, but they weren't effective at all. But what we did was we changed positions. We got her on all fours. Then when she wanted to lie down, we put her in the throne position. And then there was a point in time where she said she wants to close her legs, and she was saying she needs to poo. And I was like, this is a good sign, like that baby's coming if you need to poo. It's probably baby's head. And as she was pushing, the pushing was getting better. And vertex was visible, but it's like baby's head comes out and goes back in, comes out and goes back in. So it's a rocking motion, but she wasn't using the full contractions properly. But it's okay, like it was her first baby, and you don't know how to do these things, innit? So yeah, it was fine. And she was doing well. I was really proud of her as well, because she did have the epidural, and the doctors had come in. They was like, okay, so you've got 1 hour, and we managed to get an hour and a half of her pushing and stuff. So I applied a warm compress on her perineum to stop it from tearing and stuff, but she kept pooing, so the warm compress would get dirty. There'd be poo in it, so I couldn't use it anymore. And then the midwife was talking about guarding the perineum in a certain shape, but I was saying that I'd rather the warm compress, because I don't know the evidence of doing this thing or all of that stuff that they do to guard the perineum. I don't think it actually helps, in my opinion, but I should do research on it, so don't listen to me. Yeah, so anyway, basically we done that, and then we put her in the throne position and we put her on stirrups with her legs up, and she was very uncomfortable with that. She wanted her legs down. So soon after we put her legs down, then a doctor came. The doctor wanted her legs back up. So we did that, and the doctor said it's been 1 hour 40 minutes of active pushing. So what we'll do is give you 15 more minutes. If we don't see baby, then we'll give you the help with the 1-2s or the forceps. And she said probably the 1-2s. But then me and the midwife were just a bit like, okay, in my head I'm like, where's this 15 minutes coming from? Like, what is the right amount of time a woman can push? Because every woman is different. It was just like a random 15 minutes. And I was like, sometimes I feel like they just want something to do. I didn't understand why. Because baby's heart rate was fine. Like, the fetal scalp electrode was actually on baby's head, so we were really picking up great heartbeat, it was great connection and everything. So I didn't see the reason why, but yeah, so after the doctor said that, we continued pushing, and I had to take off my gloves because the doctor wanted to scan her. And the doctor scanned her and was like, oh, baby's transverse. Me and midwife were looking at each other like, what? Because we both done the VE and baby was not transverse. Transverse means like baby's a bit like diagonal. And yeah, baby was definitely not transverse. So she continued to scan and stuff, and she was like, oh yeah, baby's ROA, like we had said before. I was like, yeah. So anyway, she went out. She said she's going to get the instrumental trolley. Baby started pushing. I was so proud of her. Yeah, anyway, okay, so she put in her gloves. I put on my gloves. But then she was guarding the perineum, and then her hand was on top of baby's head, which is generally how we deliver the babies. So it's slow and at ease, so the woman doesn't tear too much. So that was fine. But then I was like, I'm supposed to be doing this. Like, I'm the student in it, and I'm the one who needs to help mom get birth her baby for my numbers as well. So I was like, you know what? Okay, we'll do it together. So I went to put my hands there too and everything. But then she was like, can you feel cord? And I felt cord, but cord wasn't wrapped tight around baby's neck or anything, but she was feeling inside the vagina to see if there's enough space for baby to be birthed. Maybe mum would need an episiotomy, we didn't know. So I let her do that. And then I was still having my hands in the area. I was confused at like why she was there, like, because of course I can do it. Like I can do it. So what I concluded afterwards was that, okay, let me tell you that after. Anyway, so at a point in time, head was out. Beautiful baby, lots of hair and everything. Head was out. Sorry, talking so much is making my throat dry, and this weather change. Yeah, it's so cold. Anyway, so baby's head was out, but was out for like 3 minutes, and that she wasn't getting a contraction for the body to come. So me and the midwife literally did axial, I'm saying it right. Let me just say downward traction for baby to come out, but the midwife noted that baby's in a compound position. She was closer, so I couldn't see. So baby was literally coming out with the hand there. She's like, oh, your baby's a superhero coming out like that. And the dad started laughing. And then 3 minutes later, baby was out. So immediately, I had already put a towel on mum's chest. Put baby in the towel, stimulated the baby. but we couldn't hear her cry. The baby's colour was good, the baby looked fine, but we couldn't hear her cry. We could hear like little bits, and we kept stimulating baby for a good 1 or 2 minutes, and then she was like, okay, call the call bell. Then she was like, no, call the emergency bell. We just need the peds at least, or someone to come and check baby. I still have the emergency bell sound ringing in my ears. Oh my gosh, it's so loud. But then everyone came into the room. We quickly clamped and cut the cord, took the baby to the resuscitator, and they were just stimulating baby. But the midwives were saying, baby's fine, why did you blah 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 blah. But it's better for us to call in if we think it's an emergency and we're not sure, than it being an emergency and we don't call and something happens. But yeah, so baby was fine, baby started crying, just needed a little bit more stimulation. Brought baby back to mum. We brought baby back to mum, and yeah, mum done skin to skin with baby, and it was all cool, not too much bleeding at all. They were saying, oh, we'll get 40 units ready, and basically, so no, the midwife gave mum syntocinon, just because her blood pressures were a bit iffy during the labour, so wasn't sure whether to give her syntocinon or not. Because if a woman's blood pressure is high, you don't give her syntocinon, because it has ergometrin as one of its ingredients, which increases blood pressure. Yeah, when I was guiding the placenta out using downward traction, she was asking me whether I had any hindrance, whether I felt like I was pulling too much and that sort of thing, and I said no, it's fine. I had confidence in that. I've never pulled a cord off before, and I never want to. I think that's one of my biggest fears. Yeah, pulling the cord off, then the mother, after all of that, has to go to theatre and have the placenta manually removed. I can't. So whenever I feel anything stopping me from the placenta coming out, I just stop. But this was fine, and then I had also asked her to give me a few pushes, and that really helped, and the placenta was just there anyway. So delivered the placenta, checked over the placenta, got cord gases from the placenta, which was, they were fine. I hadn't done it in a long time, so another student had actually helped me just to remember how to do it, which wasn't too bad. It's self-explanatory. No, it's not online, it's not self-explanatory, but basically a placenta contains 2 arteries and 1 vein, but the arteries are quite small. So basically you're using a needle and a syringe to take out blood from the artery, needle and syringe to take out blood from the vein, basically. Yeah, and then check over the placenta, and placenta was intact. I did find a huge blood clot in the placenta, but it was fine. So when I went back to the room, the midwife had started suturing, and yeah, mum had a 2nd degree tear, and I generally thought she didn't have a tear, but thinking about it, because it was a compound presentation with the hand, then that's probably why there was a tear. If not, the way the head came out was so controlled, so I don't think a tear would have occurred. But I done babies checked, I weighed baby, I gave baby vitamin K with their consent. Vitamin K is for blood clotting, because babies don't have much vitamin K, so it's something that's offered to parents. And then I also measured baby's head circumference and baby's length, and what else did I do? Took temperature and took heart rate. I know not all hospitals do this, it's different, but I just do it to be on the safe side, just to see if baby is in normal parameters and is okay. And then baby was doing a lot of rooting and then putting hands in the mouth. As soon as we put baby on mum skin to skin, she was so comfortable. None of that. So she stayed skin to skin for a bit. And yeah, that's how the shift went. Students are actually a blessing, for real. And not to say that, oh, I was a blessing today. I'm not even trying to say it like that. But for real, because there's so much to do after baby is born. Like, you need to okay, so birth the placenta, help the mother birth the placenta. They need to check if there's any tears. If there's any tears, that needs to be sutured. But at the same time, you've got baby, and you need to make sure baby's okay. And then they need to do observations on mum too, and make sure she's okay, and then make sure she's not feeling any pain if you're suturing. But then with baby might be, maybe baby want to feed and skin to skin with mum and stuff, and then you've got to weigh baby, do baby's length, check baby's length, administer vitamin K if the parents have consented to it, measure head circumference, check baby's heart rate, check baby's temperature, and it's not all bad, it's amazing stuff, but it's actually a lot. One person is a lot. So midwives need to be fast, and that's what I need to practice. I'm going to start going gym again and going on the treadmill and being fast, because I think I'm quite slow. I need to speed up with stuff. But all in all, I loved it, and I'm excited for the next one. I'm going to sleep now. Peace.